right. Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Post-Mastectomy Pain Syndrome. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Without further ado, I introduce our workshop speaker. Dr. Philip Chang is an assistant professor in cancer rehabilitation medicine at the Samuel Oschin Comprehensive Cancer Center at Cedars-Sinai. He has published on various topics in cancer rehabilitation and works with the Cancer Rehab Physician Consortium, the American Academy of Physical Medicine and Rehabilitation. Thank you so much, Dr. Chang, for being here with us today.
Thanks so much for inviting me to speak in, Rebecca. Since it looks like we just have a smaller crowd today, or if there's any questions that pop up during, I might just answer them during. I will throw up my slides here. So is that showing? Can everybody see that? I could get yes.
Yes, thank you.
Oh, thank you. Okay, great. Okay. So let me pointer. Okay. The topic of this seminar is going to be post-mastectomy pain syndrome, or kind of the abbreviation that we commonly use for this is just PMPS. So we'll go ahead and just dive right into it. So to start, I do not have any disclosures. Excuse me. You know what? I actually forgot to go into presentation. So let me do that again in this interview. So sorry about that. All right. So to kind of just get right into it, I'd just like to talk about all the different terms that kind of have been used to more or less describe the same thing. So kind of, the title of this seminar is post-mastectomy pain syndrome. This is a fairly old term that was first coined by Dr. Iris Granick in the 1980s. And it wasn't really formally defined, this syndrome, until a couple years later by the International Association for the Study of Pain. But basically, throughout the years since then, there have been a number of different terms that have been proposed to basically describe the same pain syndrome, which essentially is pain involving kind of the breast and chest wall area, as well as the arm on the side of the surgery. For anybody who undergoes surgery in the breast area, or usually surgery for breast cancer. So you can see that there's a bunch of different terms here, and they're basically trying to describe it as either pain from nerve damage. Some people are saying that it should be pain that's present kind of like every day, and it has to at least be 3 out of 10 on like a pain scale. And other people are saying it has to be present for like a certain number of months, although there's disagreement about whether it's like 3 months or 6 months. And more recently, there's been kind of this push towards this other term called post-breast surgery pain syndrome, because the term post-mastectomy pain syndrome makes you think that it could only occur with mastectomies, when again it could really occur with any kind of breast surgery, including lumpectomies. All of these things are basically describing the same thing, but today we're just going to be calling it post-mastectomy pain syndrome. So what is this? Again, this is a kind of neuropathic pain, and all that means is that really traditionally it's been thought to be caused by nerve damage from when they're doing the surgery. Either they're cutting through nerves or kind of cutting around nerves and damaging them in some way, and it's the damage of that nerve that's causing this kind of pain. And similar to other kinds of nerve pains, the types of sensations that are felt are usually sharp or stabbing sensations, along with sensations of like tingling and numbness. This pain is typically present on the chest wall or upper arm area, and most people will say that it has to be present for at least 3 months following surgery to be considered post-mastectomy pain syndrome. Now, a lot of people will have pain in these areas of the chest and upper arm after surgery, for maybe weeks or even a couple months after surgery. More often than not, I personally will call that just post-operative pain because we expect people to have some pain following those kinds of large surgeries. Yeah, once it becomes kind of lasting longer than it should, and really continuing past the time after we would have expected someone to heal, then we'll use this term post-mastectomy pain syndrome. And again, other causes of kind of more chronic pain or recurring pain, such as infection, should have been ruled out. Just to note, PMPS, there's no standardized definition. So again, some people will say that pain should be present for 3 months, others like 6 months, others 9 months. I personally kind of go with the 3 month rule. Yeah, as long as it's kind of chronic, then we'll term it PMPS. So there's like a wide ranging incidence of how often this occurs kind of following breast cancer treatment. So you can see that all these different studies have showed incidence ranges of kind of this chronic pain after breast cancer of like 12 to 50% or 20 to 72%. In reality, it's probably not, this common as occurring like in 60 or 70% of people. More likely, the nerve damage type of post-mastectomy pain syndrome probably has an incidence rate somewhere closer to maybe 20% or possibly like 25%. So what are the main symptoms that we see in this, and how do we diagnose it? So this is what we call in medicine a clinical diagnosis, meaning that we really make the diagnosis just based off of the symptoms that someone is presenting with, as well as her findings on clinical exam. So basically, if you had surgery on the breast area, and that could be either lumpectomy or mastectomy, or an axillary lymph node dissection or a central lymph node dissection, or any combination of these kinds of surgeries, and you do have kind of chronic pain in the area of the upper arm as well as the breast and chest wall on the same side that you had the surgery on, and it has kind of those more neuropathic sensations of, again, burning, tingling, or sharp stabbing pain, then it's a very good chance that we'll call this post-mastectomy pain syndrome. But just because you have pain in that area of the upper arm or that side of the chest, it doesn't mean that it's necessarily nerve-related typical post-mastectomy pain syndrome. This is a diagram basically indicating that there are multiple other causes of pain kind of in this area of the arm, as well as the chest wall, that are not caused by typical post-mastectomy pain syndrome that may be occurring, but it could be kind of looking like it's post-mastectomy pain syndrome because, again, it's in the distribution of this area. So, for example, if you have a shoulder problem, like as demonstrated by this yellow shaded area, a lot of people have pain in the shoulder that's caused by frozen shoulder. It could kind of look like post-mastectomy pain syndrome, but really it's being caused by the shoulder. And it's important because that will have a different kind of treatment. And sometimes you can have something called shoulder impingement syndrome, where you had pinching of the structures of the rotator cuff in between a couple of the bones in the shoulder. And again, it's kind of in that area where we expect to see post-mastectomy pain, but it's not really being caused by nerve damage from the surgery. So while it looks like it, it's actually really being caused by something else. And there's a couple other examples here. For instance, sometimes post-mastectomy pain syndrome, it will kind of go down the arm, but there's other causes of pain that can go down the arm, including a pinched nerve in the neck that we call cervical radiculopathy. And that, again, can cause neck pain and pain shooting down the arm. So again, even though it's not typical post-mastectomy pain, or post-mastectomy pain syndrome, as defined by being caused by the surgery, nerve damage directly from the surgery. It can look like it. So I just kind of want to throw these slides in here to really illustrate the point that, you want to try to dig down and find the underlying cause as much as possible, because all these things will really have different kinds of treatments. And another way to look at it is just kind of illustrated here, where you undergo one of these kinds of breast surgery, and then again, you have kind of the immediate pain that develops after the surgery. And again, I usually just call this post-op pain. Some people may get phantom breast pains and phantom sensations, although this is pretty rare. And the post-op pain is just from the incisions that they make. You may develop some fluid collections that are called seromas, and some people unfortunately do develop infections, and these can all lead to pain. But typically, these should all resolve in a matter of maybe weeks to maybe a month or two. So at some point, if pain is kind of continuing beyond this, for a 3-month period or a 6-month period, then we start calling it chronic. And what's this chronic pain? Again, there's so many different causes. There could be kind of classic nerve damage causes that we would attribute to regular post-mastectomy pain syndrome, but there could be a number of other causes, like I said, if you develop frozen shoulder or shoulder impingement syndrome, or if you developed muscle kind of imbalances causing muscle pain. All these things can kind of cause pain in the same areas where, again, it looks like post-mastectomy pain syndrome, but it's not exactly. And it's just important to pinpoint the diagnosis as much as possible so you can get the appropriate treatment. So with that said, I basically want to go through a lot of the classic kind of neuropathic causes, as well as kind of these other muscle related causes of pain, all in this area, that as well as the treatments that you would do for each of those things. So again, these classic neuropathic causes are going to be more in line of what we typically mean when we talk about post-mastectomy pain syndrome, and these other muscle-related kind of causes of pain are going to be things that are not exactly the typical post-mastectomy pain syndrome, but they can look like it. So we'll start off by just talking about the traditional neuropathic causes of pain. So really, I kind of group this into 4 specific kinds of nerve damage that can occur. So the first is intercostal brachial neuropathy. The second are intercostal branch neuromas. The third is neurogenic thoracic outlet syndrome, and the last one is scapulothoracic bursitis. So we'll be talking about each one of these in detail. But first, I just want to go over some terminology. So you may hear a lot of different terms out there regarding nerves and the nervous system. So when you hear the term central nervous system, that basically means the brain and the spinal cord. When we talk about the peripheral nervous system, that means all the other nerves in our body that are not the brain or the spinal cord. When we talk about peripheral neuropathy, this is just a general term that talks about any kind of dysfunction of nerves in the peripheral nervous system. When we talk about polyneuropathy, this is basically when multiple nerves are affected or injured in some way. And then when we talk about, distal symmetric peripheral neuropathy or distal symmetric polyneuropathy, it's multiple nerves that are being affected, typically in the hands and the feet. And this is more what happens when you get neuropathy from like chemotherapy. So most of what I'm going to be talking about here falls into the category of peripheral neuropathy, which again is just the general term referring to any kind of disorder of the nerves of the peripheral nervous system. So just to kind of show you the picture form, the brain and the spinal cord make up the central nervous system. And then all these other nerve branches that come out of the spinal cord, these are all the peripheral nerves. These all make up the peripheral nervous system. And the nerves that are typically implicated in causing post-mastectomy pain syndrome are kind of the nerves that go down the arm, as well as the nerves that wrap around each of the ribs, which are the intercostal nerves. So we'll go into more detail now on kind of each of those 4 classic neuropathic causes of post-mastectomy pain syndrome. So the first one is intercostobrachial neuropathy. And I know this is kind of a mouthful, but basically this is just talking about damage to the intercostobrachial nerve. So this is a nerve that essentially wraps around your second rib, and then it crosses your armpit, and it provides sensation to the back part of your arm and kind of the inner part of your arm. So you can see the intercostobrachial nerve right here. It supplies sensation to this green area of skin. And this nerve is very, very commonly damaged in anybody who undergoes an axillary lymph node dissection or a sentinel lymph node dissection. Very, very frequently damaged. So people very often get numbness here, and sometimes they'll also get pain in this area. And, you know, this is probably one of the most common causes of true neuropathic post-mastectomy pain syndrome. So you can see again here the kind of the nerve kind of coming out here, and you can see it kind of crosses the armpit area and then goes down the arm to provide sensation again to this area. And again, this can be frequently damaged in people who undergo lymph node dissection surgeries. So, you know, whenever somebody has kind of a nerve-related pain, a lot of the times the primary way of treating it will be through nerve pain medications. And these are the very most common nerve pain medications that are used. For anybody present here who's undergone surgery, you've probably heard of like gabapentin or pregabalin or Lyrica. These are probably the #1 used medications, but if these aren't helping you, there are other medications that you can talk to your doctors about. Another very common class of medications are called TCAs, which stands for tricyclic antidepressant. These are going to be medications like amitriptyline and nortriptyline. So again, if for whatever reason, gabapentin or pregabalin is not working for you, you can talk to your doctor about considering one of these. And then there's another class of medication called SNRIs, which stands for serotonin and norepinephrine reuptake inhibitor. And these are going to be medications like duloxetine or Effexor. And sometimes these can help with this kind of pain as well. And, you know, you can see some other things like cannabinoids, which would be medications derived from cannabis or opioid type medications. So these are all the typical medications that we get for nerve pain and for somebody with having post-mastectomy pain due to, again, injury of the intercostobrachial nerve. We may consider treating with these medications. Another thing that we might consider treating with are different topical medications. A lot of times what I'll recommend to my patients is that, you know, they can, a lot of these are available over the counter, but we might recommend that they trial, probably the most effective would be like lidocaine. And you can get usually 4% lidocaine over the counter at any retail pharmacy, and you just kind of apply it to the painful areas. For other people, menthol-based topicals will be more effective, and these are going to be all of your topicals that kind of have that minty smell. So it's going to be things like Tiger Balm or BioFreeze or Icy Hot. There are various marijuana-related topicals that have CBD and THC in them that can be helpful for other people, for a lot of people. The latest skin food is something I frequently recommend to people who kind of have tightness-related radiation. Sometimes that can be helpful. Compound creams are essentially specialty made customized creams that you would get from a compounding pharmacy where they just mix a bunch of different medications together into a cream. These are usually expensive and don't work super well, so I don't do this too often, but it is an option. And something that we've been doing a lot more recently in our clinic here is capsaicin. So capsaicin is basically a compound that's derived from spicy chili peppers, and it's basically the component of spicy chili peppers that makes it, you know, spicy. It gives it the actual spicy feeling, like kind of burning in your mouth or your tongue. The way that this works is it basically overstimulates the sensory nerve receptors to the point where they stop working very well and they become desensitized and they're not able to transmit the pain signals as strongly anymore. So there is prescription grade capsaicin in this patch called Qtenza And this is another option that actually we've been finding can work fairly well for post-mastectomy pain syndrome, including damage to the intercostal brachial nerve. So this is a problem you've been dealing with for a long time, this kind of therapy with this capsaicin might be something to consider for your medical team. And then lastly, we can kind of just block the nerve. So essentially what this is showing here is an injection that would be a nerve block to the intercostal brachial nerve. And this is usually done under ultrasound guidance. And usually they just inject a little bit of local anesthetics, such as lidocaine, in addition to a steroid. And there's a little bit of evidence, these are not very large studies, but there's a little bit of evidence that these can be helpful for pain, specifically in the distribution of the intercostal brachial nerve. So I'm just seeing a question right here, so I'm just going to read it right now. Do any of these meds, such as Lyrica or Cymbalta, cause weight gain? Which one causes the least weight gain? So very good question. I'm not sure, or I would say it's not common. One thing that can happen with Lyrica, as well as gabapentin, is that maybe somewhere between 5 and 10% of people can get swelling. So it can cause swelling most often in like the legs and the feet. And if that happens, that will usually be associated with like just kind of the fluid weight gain. But as far as I know, it's yeah, weight gain is not a common side effect of medications like Lyrica and gabapentin. I believe for Cymbalta, I think it's possible, but I would have to double check that honestly. But if it does, it's certainly not common. But there are other more common side effects with medications like Cymbalta, such as upset stomach, nausea, headache, as well as kind of different effects on mood, because it is also commonly used as an antidepressant. Thank you so much for that question. Okay, so moving on here to our next pain type, are intercostal branch neuromas. So, what does this term mean? So we'll just kind of break it up here. So intercostal branch just means that it's talking about the nerves that wrap around each of our ribs here. So you can see this is one of our ribs, and you can see kind of this nerve coming all the way around to the front. And this is called the intercostal nerve, this nerve kind of wrapping all the way around. And this intercostal nerve gives off these branches that we call cutaneous branches. So you can see the posterior branch here, and the lateral branch. You see another lateral branch, an anterior branch. And essentially, these are the nerves that give sensation to the skin in our chest and as well as the breast area. So you can imagine that, when they're doing these surgeries, if they cut or kind of damage one of these nerves, then, it would cause numbness, but it could also cause pain in the area all around the chest wall, in addition to the breast tissue. And what a neuroma is kind of what can form when the nerve is damaged. So there's two kinds of neuromas. One is called a terminal or an end neuroma, and this would happen if the nerve is just fully cut. What would happen is you get kind of like a little ball that forms the end of the cut nerve, and this can be very, very painful and sensitive because essentially it's just an open ball of free nerve endings. The other type of neuroma is called a neuroma in continuity, meaning that the nerve isn't cut, but there's like an area that's been injured, so it kind of balloons up in the middle, but then there's it kind of continues on as the uninjured part of the nerve. So these are the kinds of pain that we think are happening when people are getting more pain in the chest wall, either on the side or in the breast itself. So, what can we do about this? One of the major things that we do is something called the trigger point injection. So this is a little bit of a misnomer because trigger point injections are usually describe injections that are done into kind of painful muscles, where they kind of usually just inject steroid or lidocaine or normal saline into painful muscles to treat muscle-related pain. In this study, they're calling these trigger point injections, but really what they're doing or what they believe they're doing is they're doing nerve blocks to these nerves for areas where we think that there are these kind of neuromas from damaged nerves from the breast surgery. So what they did in this study is that for a lot of people it's kind of post-mastectomy pain, they took a little bit of local anesthetic. The anesthetic that they use is bupivacaine. And then they used a little bit of steroid. The steroid that they used was called dexamethasone. And they found kind of the exact points where patients had the worst pain. And then they injected those areas with a little bit of lidocaine and a little bit of steroid. And what they found was that among 91 different points treated, they had over 90% success rate, and it seemed to provide relief lasting more than 3 months. So this is something I do in my clinic quite a bit, and it's nice because you kind of know right away if it works because people will usually have relief like within minutes following the injection. So that's always really nice. We definitely need bigger studies and kind of more well-done studies to kind of prove that this is in fact true. But again, this is something that can be very helpful for some people with pain kind of on the chest wall or the breast area that can provide near immediate relief. Now, the other things that we can do for these kind of intercostal branch neuromas are surgical interventions. So let's say you get a shot and like it kind of helps, but the pain comes back, and then you try that a couple more times and the pain goes away for a little bit but keeps coming back. Then you might want to consider a surgical intervention, and there's a few that they're doing for this now, although these are kind of all relatively newer. But probably one of the most commonly done things is just fat grafting. Well, they just take some fat out from somewhere within the body, and then they'll kind of graft it to the areas of pain. Another one is called targeted muscle reinnervation, which is very similar to regenerative peripheral nerve interface. And in these surgeries, basically, they take kind of the nerve that's been damaged, and then they kind of sew it into a muscle that's nearby. So you don't have all those free nerve endings that will be very, very sensitive to any kind of pressure. But those nerve endings will be able to grow into the muscle. So they're not as sensitive anymore. And basically in dermatosensory peripheral nerve interface, they do the same thing. But as far as I know, they basically embed the nerve into skin tissue instead of muscle. But all these procedures are basically trying to get rid of the free nerve endings so they're not so sensitive anymore by giving those free nerve endings something to grow into. Okay, I'm seeing another question here. Why does back grafting work for nerve pain? That's a really great question. I honestly don't know. But it is something that's commonly done by some plastic surgeons, and it does seem to help. The only reason I can think of kind of off the top of my head, and I don't know if this is true, but I think if it just provides more cushioning around the nerve to provide like a protective barrier. So if there's anything outside applying pressure, like clothing, it could be protective against that. Or, if there's more cushioning around it, then it may make it less susceptible to like kind of traction or pulling forces. But I'm honestly just guessing, and I'm sorry I don't have a better answer to that one. Thank you for the question. Okay, moving on to kind of the third type of traditional neuropathic post-mastectomy pain syndrome is pectoralis minor syndrome, and another name that we sometimes call this is neurogenic thoracic outlet syndrome. So essentially, this is not very common, but we do see it from time to time. But you have your pectoralis minor muscle right here, which connects to some of your ribs, and then it connects to your shoulder bone. And then going right underneath that pectoralis muscle is this bundle of nerves that we call the brachial plexus. And essentially, if this muscle becomes more tight, as we often see in patients who undergo surgery or radiation therapy in breast cancer, it can put more pressure and squeeze, the muscle will put more pressure and squeeze on these nerves that are going underneath it. and that will essentially cause kind of shooting pains and tingling sensations down your arm. And typically, the most common nerves that we see affected are in the distribution of this C8 and T1 area, where it's kind of the middle of the arm, as well as kind of like the pinky side of the hand. And the reason why these tend to be more affected is just because of the way that the bundle of nerves goes underneath that pectoralis muscle. So if you are having symptoms in this kind of distribution, this is definitely something to consider. And one of the ways that we test for this, there's actually a couple of different tests. But one is called the Adson's test, where you're just going to pull your arm out to the side. Another one is called the Ruse test or the East test, where you can raise your arms up like this and then squeeze kind of over and over and over. And, essentially what will happen is you could get, when doing these kinds of maneuvers, you can get, and these are, honestly, things you could just try by yourself at home, but you could feel like sensations of like numbness or tingling, or just shooting pains going down the arm. That would be indicative that maybe, again, you have pressure of that brachial plexus bundle of nerves underneath the pectoralis muscle. So what do we do about this when we see it? Really stretching is enough for a lot of people, because if you just kind of stretch and loosen up those pectoralis muscles through stretches such as those shown here, then it can take some of the pressure off of those nerves to kind of resolve the symptoms. And oftentimes, if that doesn't work, then I'll actually use botulinum toxin, which is a medication that basically makes muscles relax. So anywhere you have tight muscles, you inject it with botulinum toxin, and the muscle kind of automatically relaxes. And we'll just inject that into directly like the pectoralis major and pectoralis minor muscles. And a lot of times that can alleviate the pressure from those nerves. So the last kind of cause of the traditional nerve pain that may occur in post-mastectomy pain syndrome is called scapulothoracic bursitis. So really quickly, bursitis is when you have inflammation of a bursa. So what then is a bursa? Bursa is basically a little sac that's filled with fluid. And basically these sacs, they're really thin, first of all. So it's not like, like wide or open. They're very thin. And they sit between bones and tendons, or muscles and bones, or muscles and tendons, and they allow all those structures to glide against each other, so there's less friction. But unfortunately, sometimes these bursa can become inflamed. When that inflammation occurs, they can become very painful. And in scapulothoracic bursitis, you have this bursa underneath your shoulder blade bone. And when this becomes inflamed, you can kind of see that it would be kind of in close proximity to all those nerves going out the spinal cord. So what we think happens is that the inflammation from the bursa may also cause the inflammation of the nerves going around each one of those ribs. And that's why you can kind of get, if you have this problem, you can get kind of shooting pains going around the chest wall area, which is something we sometimes see. So they actually did one study on this where a lot of people had breast and chest wall pain, and I believe it was half of these individuals in the study who basically had this pain attributed to surgery following breast cancer. And what they found was that this was kind of the under-recognized cause of breast pain in 22% of these 400 patients. So when we see this, well, sometimes it will just respond to non-steroidal anti-inflammatory medications. So this is going to be things like high dose ibuprofen or naproxen or meloxicam. We always try to do muscle rebalancing, where we try to strengthen kind of all the muscles around the shoulder blade bone while stretching out the pectoralis muscles. And if that doesn't work, then this is something that can respond well to injections, where essentially we just inject a little bit of steroid directly into the area of this bursa beneath the shoulder blade bone. And this is kind of the same study where they also looked at injection to see how effective those kinds of injections would be. And they found that over 80% of patients who underwent these injections for scapular bursitis had complete resolution of their chest wall pain. So those were kind of all the causes of the classic nerve-related post-mastectomy pain, where again, that's caused directly by you get surgery, and surgery they kind of cut or damage those nerves, either going around the ribs, called the intercostal nerves, or maybe there's damage to the intercostobrachial nerve. That's the one that goes to the inner part of the upper arm. So now I want to kind of shift over to kind of all these other kinds of pain that will occur in the same area. So, you might think that it's post-mastectomy pain, maybe even nerve-related post-mastectomy pain, but really it's being caused by something totally different. And some of those other possibilities are musculoskeletal. So, again, not coming from the nerves being damaged, but more coming from either muscles being damaged or tendons being damaged or inflammation of like the joint. And it's important again to know just because those will have different treatments. So see another question here. Do you notice any increased incidence of neuropathic pain syndrome in patients who have had latissimus dorsi flap as part of the breast reconstruction? That's another very good question. Think about this for a second. I'm going to say yes, but not necessarily of the nerves that I talked about so far. So not necessarily of like the intercostal nerves that go around the ribs, but there is a greater incidence, possibly of other nerve damage, So yes, just because kind of that tends to be a larger surgery, I can say yes. But yeah, off the top of my head, I'm not aware of exact numbers or even anyone's looked at that yet. But yes. Okay. So delving into these other musculoskeletal sources of pain. Again, pain not coming from nerves, but coming from either the muscles or the tendons or the joints or the ligaments even. It really stems from this picture that we see right here. So, this is kind of a picture of somebody with good posture. They're kind of standing up straight, and, their shoulders are back a little bit. So, all their muscles in their back are happy. All the muscles like in the chest are happy. And, this is the picture that represented probably most of us who kind of sit at a computer, like, for a lot of the day. Or, for somebody who has undergone like these surgeries, like a mastectomy, or a lumpectomy, because after you undergo this kind of surgery, it's really natural to kind of hunch your shoulders forward to protect the area that just underwent surgery. And when you do this, you can see that it's going to cause a lot of strain to a lot of the muscles kind of in the back of the shoulders as well as the neck area. So because of the results of that changing in posture following surgery and radiation, it's leading to the forward movement as well as the depression of the shoulder. And when you get that different positioning, it can increase your chance of getting these things, including shoulder impingement syndrome. We'll go into each of those in detail, but before we do that, I just want to make a note that one of the things that we think can be helpful prior to undergoing these kinds of surgeries, especially if you have like maybe a surgery plan but haven't undergone it yet, we think that basically exercising before your surgery for a few weeks and trying to increase the mobility of your shoulder area as much as possible could may reduce your chance of getting one of those problems, either shoulder impingement syndrome, myofascial pain, or frozen shoulder. So, these are really simple exercises of just kind of like bending your arms backwards and kind of stretching from side to side and doing these kind of like snow angel things while standing up. But through these kinds of exercises and increasing shoulder mobility beforehand, this could be a potential strategy of mitigating the incidence at which these other problems can occur. Okay. So starting off with shoulder impingement syndrome, even if you haven't undergone any kind of treatment for breast cancer, this is already one of the most common causes of shoulder pain. If you have shoulder pain, there's a good chance that it's from shoulder impingement syndrome. And essentially what you have is between these two bones here. So your coracoid, um, I'm sorry, your acromion, and the head of your humerus. When you basically lift your arm up, all these structures can become pinched, including these various ligaments, different tendons from the rotator cuff muscles, as well as the biceps tendons. They can all become pinched between these two bones, and kind of the hallmark finding is if you have like really bad pain in the front of your shoulder, you can't sleep on that side, or if you like try to reach up above you, any kind of overhead motion will like create a lot of sharp pain in this area. And we just think that when you kind of again get surgery and you have those altered positionings, that altered posture, that can increase the chance of this happening. So when it does happen, the treatment's pretty simple. A lot of people will just respond to physical therapy and kind of these kinds of stretches that open up the space within the shoulder joint. And if that doesn't work, then a lot of times you might pursue something like a steroid injection, which works well most of the time. And if that's not working, then we might send you to an orthopedic surgeon for consideration of surgical management. But I don't think I've ever really had to send anybody to this before. And usually these injections are just stretching and exercise for almost all the time. Um, the second thing, complication that can happen, so again, something that could look like post-mastectomy pain syndrome, but isn't really, is adhesive capsulitis that we also call frozen shoulder. So frozen shoulder is basically when you get scar tissue formation and kind of stickiness due to inflammation inside of the shoulder joint. And that basically makes it hard to move because all the tissues inside of the joint are sticking to each other. There have been some studies that basically show that uh, patients who undergo kind of surgery for breast cancer, they can get a higher incidence of this, like at 7 to 10%. That said, other studies have showed that the incidence rate may not be that high. As this study reports 3.8%, which is kind of more in line with, the incidence in the general population that doesn't have breast cancer. But the point is, it's more likely somewhere between these two numbers, and it probably does occur commonly. I'm seeing another question here. What type of doctor does these steroid injections? So, great question. More often than not, it'll be an interventional pain management doctor. So somebody who has background training in anesthesiology or similar background training to me in physical medicine and rehabilitation. But more often than not, it will be an interventional pain management doctor is the kind of specialty that you're looking for. Okay, so frozen shoulder there's three stages. The first stage is the freezing stage where there's like a lot of pain in the shoulder with progressive loss of range of motion stiffness. And then the second stage is the frozen stage where there's not as much pain anymore, but it continues to be stiff and you can't really move it that much. And then the final stage is the thawing stage where you start to get increase in range of motion back. So there are, you can see that there's a wide range of months for how long each of these stages can last. So, it can really honestly be anywhere from like 1 to 2 years to kind of go through everything. And in that sense, frozen shoulder syndrome is typically considered to be a self-limiting disorder. Although after somebody goes through all the stages, some people may have persistent symptoms where they basically don't get their full range of motion back. So, how do we treat this? Again, it's just through a lot of exercise and basically moving your shoulder around. So we'll basically send everybody to physical therapy. And, they'll have you do these various exercises to try to increase your shoulder mobility. And, one of them is like this kind of wall climb exercise that some people may be familiar with. And if these things aren't working, then, we'll do another kind of injection directly into the shoulder joint. We are tend to inject high volumes of a local anesthetic in addition to a steroid that can sometimes help people get a little bit of range of motion back, but if it can't do that, it will at least help with a lot of the pain. And there are kind of newer procedures now. Kind of the newer one is called hydrodilation, where we will basically inject a large volume, maybe 10 to 20 milliliters or more even, of normal saline inside the shoulder joint to try to open it up to, again, kind of make it less sticky inside to increase range of motion. Okay, the last kind of pain syndrome that can occur that's can kind of masquerade as post-mastectomy pain is myofascial pain. So this is myo basically just means muscle, and fascial just means the connective tissue that surrounds the muscle. So this is a type of pain that is caused by muscle, and it's really characterized by what we call trigger points. So trigger points are top bands of muscle fibers, where if you kind of press on them, it causes pain, and it will also cause pain in some other areas. And we think that a lot of this is, again, due to kind of our altered posture and the mechanics of, what our shoulders look like. So again, we see this picture where his shoulders are kind of drooped forward and down. And that puts a great deal of strain on all the muscles in the back here, as well as in the neck. And, that could cause this kind of myofascial pain in those areas. So, with the trigger points is what we see, and then where you see an X is kind of where you push on it and it's tender. And these red areas are basically just highlighting the referred pain patterns that you'll see. So, if you push down here, you'll feel like pain up here in your neck. If you push like up here, you'll feel pain in all these different red areas. And it just depends on this particular muscle that's affected. So this is something, another thing that they understand, what they found was that breast cancer patients who underwent surgery had a much higher number of these kinds of trigger points compared to breast cancer patients who didn't have surgery. And you can see it's quite significant of 4 of these trigger points versus 1 in those who did not undergo surgery. So again, a very, very common cause of pain in those who are treated surgically. So how do we address this? We want to, address the altered biomechanics. So if we can get back to a posture where our shoulders are kind of back and our chest muscles are kind of loosened up, that's going to be the most helpful thing. So we want to just stretch out that chest and strengthen the back. And then physical therapy can help with a lot of these things, and a lot of times physical therapists will use manual therapies where they kind of use some massage techniques to loosen up all these muscles, which can be helpful for a lot of people. There's various oral medications that we call muscle relaxants that can kind of help for temporary pain relief. And for people who aren't responding to these to these therapies, we can do trigger point injections where these are different from the previous trigger point injections I was talking about, but essentially with these trigger point injections, they're just taking a needle, they're sliding it in and out of the muscle to get it to relax. And this can be useful in providing at least temporary relief. Lastly, I just briefly want to talk about radiation fibrosis because this is something that can occur and kind of worsen these kinds of musculoskeletal pain issues of frozen shoulder impingement syndrome, and myofascial pain. So, radiation fibrosis is when radiation causes tissue hardening. And when that tissue hardening occurs, you can get radiation fibrosis syndrome, which is kind of all the symptoms that occur because of it. And essentially, it's just when you get radiation, you can get a bunch of scar tissue formation. And when that scar tissue affects like nerves, then it can cause kind of muscle weakness and muscle shrinkage, as well as contributing things like lymphedema. And a lot of the effects that I often see are late delayed, meaning that even months after you finish or years after you finish radiation, you can start to get this kind of scar tissue deposition and the symptoms that result. So you can just imagine, this is like the pectoralis major muscle that if you kind of put a bunch of scar tissue here to cause it to shrink down, it'll pull your shoulder down into kind of that forward and drop position. And again, it will predispose you to, all those things that we want to try to avoid, like frozen shoulder impingement syndrome, myofascial pain. And you can imagine the same thing would happen if you're doing that to the pectoralis minor muscle, where again, it's pulling you into this posture that we call this posture upper cross posture. But again, myofascial pain back here, as well as causing the shoulder issues. So again, we kind of already talked about this. These are the different kinds of treatments for radiation fibrosis, but I just want to kind of focus on stretching really because that can be so helpful to so many people. We can kind of provide help with bracing. So instead of stretches, we just want to open up that chest wall with these types of stretches and strengthen the back to kind of pull the shoulders into that more retracted position. And sometimes we can provide help with bracing. This is an example of a figure of eight brace. I don't recommend this for anybody who has sensitivity in the armpit area because that would kind of make it intolerable. But for those that don't, this can kind of be a helpful reminder for kind of keeping a better posture. So with that, I'd be happy to take any other questions if there are any other remaining questions. And if you prefer to ask later, just email me. You can feel free to send me an email at this email address. But thank you so much.
Thank you so much, Dr. Chang. We do have a couple of questions in the chat. Would you like me to read them out loud to you, or would you like to
Oh,
read?
um, let's see. Okay, I see. Oh, yeah, I think I answered these during. Yeah, I'm sorry. I know I said I was going to wait till the end, but I've been answering these questions during. But
Okay, wonderful.
yeah.
If there are any other questions, feel free to put them into the chat, or you can unmute yourself and ask. So there was a wealth of information that was shared, and this workshop was recorded or is being recorded. I just put my email into the chat. So if you would like to review this or share this with someone who is dealing with these symptoms, please feel free to email me and I could get them out to you. All right, I am going to stop the recording.